Hey, welcome everybody. This is our webinar today on 988, the new crisis hotline. And this is part of NAMI Tennessee's Advocacy Day series. Last week, we started off with a two-day training about how to tell your story around advocacy, how to tell your story effectively, and how to reach out to policymakers. So what we're doing now is building on that, and we're focusing on the 988 hotline, as I mentioned. Next week, we're going to be talking about mental health in schools, a lot of discussion about that. And then on March 22nd, we'll be talking about just issues that mental health care advocates need to know about. So thank you for joining us, and we appreciate you being here. So I'm going to start out by introducing our speakers and just reading their backgrounds. Hannah Wesolowski, who's going to be joining us shortly, was recently promoted to Chief Advocacy Officer for our NAMI National Office in Arlington. And she has a long history of policy, advocacy, grassroots engagement. She had been Director of Field Advocacy at NAMI prior to her promotion. So she's the primary point person on everything advocacy for NAMI, and she's been great to work with. Before that, she was Associate Director of Political Engagement for the Public Affairs Council, Director of Political and Grassroots Advocacy for the American Speech Language Hearing Association. Those are the speech therapists, that's their trade organization. And then Manager of Advocacy Outreach and Political Engagement for the American Institute of Architects. So as you can see, she does have a long policy and advocacy background. And then we have Laura Evans. Laura, you want to wave? Laura comes to us today from Vibrant. You're going to hear about Vibrant's role in this 988 hotline. They play a critical role nationally. And certainly Hannah and Laura have been on a lot of national calls, done a lot of presentations on this topic. So she is the director, the National and State Policy Director for Vibrant Emotional Health. And she was the State Government Affairs Director from AAMFT. What is that, Laura? I printed out your bio from
It's
LinkedIn.
The American Association for Marriage and Family Therapy.
There you go. Got it. And then you're also you have a lot of great legislative experience, legislative affairs representative for the Association for Professionals in Infection Control and Epidemiology. Yeah, you would have been really busy these past few months if you had still been there. And then worked for Stateside Associates and was a legislative aide in the Ohio General Assembly. And then we have Jennifer Armstrong. Jennifer, if you want to wave. Jennifer is the director of the Office of Crisis and Suicide Prevention Services. And that is within the Tennessee Department of Mental Health and Substance Abuse Services. And before that, she worked for Centerstone as Vice President of Customer Engagement Operations, and then was prior to that, the Director of Crisis Care Services at Centerstone. I'm going to introduce Dorshonda a little bit later when we get to her part of the presentation. The three ladies that I just introduced are going to be speaking with you today from a national perspective on the rollout of 988. And then Jennifer with the State Department is going to be talking about what this looks like in Tennessee. So I'm going to pause and see if Hannah doesn't appear to be here. Oh, there's Hannah. There. Hi.
Computer trouble today. I'm sorry.
Oh, it's okay. It's okay. Do you need a minute? Are you good to go, or?
I'm good to go. Thank you so much. Really appreciate being here. Is it possible to enable screen sharing? If not, it's okay. I can talk through my slides.
Yes, I believe so. Let's see. I'm going to make you host. How's that?
Okay, perfect. Thank you. So as Elisa said, I'm with the National Office of NAMI. I'm the Chief Advocacy Officer, and we've been working with a lot of states and at the federal level on 988, and work very closely with Laura often. So very happy to be with her today talking about this. And I'm just going to give a little bit of a higher level overview of where we are, what the vision is, and happy to answer any questions. So just to start to talk about the scope of the problem, this is a slide that we often pull up. And can you see my slides okay? Great.
Yes.
So between 2015 and 2020, 1 in 4 people shot and killed by police had a mental illness. 2 million times each year, people with mental illness are booked into our nation's jails. And actually, this is old. We have over 100,000 people who have died of a drug overdose, and more than 47,000 people died by suicide in 2019. There's a lot of help that is needed out there. And for too long, we have relied on law enforcement to provide help that is needed in a healthcare crisis. And that's really where 988 comes in. It's an opportunity to fundamentally change and transform how we are responding to people who are experiencing the most acute symptoms and are in need of urgent care. 988 is a 3-digit number that is going to be available to everyone in every community starting this July, and it routes through the existing National Suicide Prevention Lifeline, which is run by Vibrant, which Laura represents. And there are over 200 local call centers, and I know she's going to talk more about this after. But when 988 was created, it also expanded the scope of the Lifeline to also include mental health crises. So this is about suicide prevention and a large range of mental health crises. And where we are is really trying to figure out what help is available when people dial 988. Some of that is available over the phone, but when other help is needed, what resources are available in a community? This is an important first step, but it's a first step. 988 is the gateway to a continuum of care. And I'll show a slide later, and I know Laura will speak more to this too, but about what services people get when they dial 988 and what other services might be available. But it is very rare that we have an opportunity to fundamentally change part of the mental health crisis or part of the mental health system. And with the implementation of 988 this year, we have the chance to do that because 988 is coming. People are going to hear about it. What does that mean? Without further action, we know that local call centers aren't going to have enough resources to answer call volume. We expect that to increase a lot. And those call centers are funded locally and by their states, not nationally. And so we want to make sure they have capacity to answer the calls that are coming in. We also know that the crisis services that are available are a patchwork across the country. Some areas have really robust crisis services and a crisis continuum of care, and others don't. We want a consistent expectation of what people get when they call 988. For example, if you have a heart attack and call 911, you have a pretty good expectation that EMS could be dispatched to you and help you get medical care. For somebody who is experiencing a mental health crisis, they don't have that expectation. They don't know if it's going to be a law enforcement. They don't know what kind of help might be available. And so we want to make sure that everyone everywhere has access to equitable crisis resources and crisis services. And particularly for communities that have been underserved, we want to make sure that we're building, those communities aren't further left behind, and that we are building up the resources in those underserved communities to provide the help and care that's needed. An ideal crisis response system really focuses on 3 components. 1, we've got the 24/7 local crisis call centers, someone to talk to. That's really what the 988 number will do. But beyond that, what's the continuum of care really supporting that 988 system? And so we look at other options of care. When a person needs more help than can be provided over the phone, mobile crisis teams provide an alternative to a law enforcement response. It's not the job of law enforcement to respond to mental health crises. CIT, which I know is very strong in Tennessee and has its roots in Tennessee, has done an amazing job in creating more awareness, more skills in de-escalation, more community collaboration. And that's absolutely still needed and going to be a crucial part of the process, because law enforcement's always going to play a role, but really minimizing that role and letting law enforcement focus on the job that they're there to do, and letting mental health professionals provide that de-escalation when it's needed on the scene. And then when more help is needed that can be provided on site, where does that person go? Often it's to overcrowded emergency rooms that don't have any psychiatric capacity. And we see very often across the country that people are boarded in emergency departments, meaning there's nowhere for them to go. They need additional help and they are stuck there for hours, days, weeks, sometime. That is not getting people the help they need. And so providing crisis stabilization facilities, they can often be co-located with an emergency department, but really it's providing someplace that's a warm handoff, and it's providing an environment to further de-escalate and identify what an individual really needs and what further care might be appropriate. Sometimes that might be hospitalization, but sometimes it can be community-based care. And so really building this system that provides this standard of care is our goal, in making it available across the country. It's going to look a little different in different communities, and urban versus rural, but providing something that's based on this framework of services is going to be really important to, again, creating that consistent expectation of what's available. And we found in a public opinion poll last year that people support this. 4 in 5 people of Americans that were surveyed believe that mental health professionals should be the primary first responder when someone is in crisis rather than law enforcement. Even though they had high opinions of law enforcement in their community, they think that providing a mental health response first is the right way to go. 90% of Americans support the creation of 24/7 mental health, substance use and suicide crisis call centers, which is good because that 988 is coming and we already have these call centers doing this great work across the country. But paying for it, people also support federal, state, and local funding for it, and are willing to, various mechanisms that can pay, whether that's federal funding, whether that's state appropriations, whether that's monthly fees on phone bills. There's lots of ways that we can pay for these services. And overwhelmingly, people support doing that because they know it's the right thing to do. And if they need these services, they want them in place in their community. And so this is just a broad overview of all the things that are happening. There's a lot that needs to happen at the state level in terms of providing funding, coordinating all of the emergency systems, and building the capacity statewide. But there's also a lot that needs to happen at the federal level, which we're working on, advocating for funding to build up that Lifeline capacity, both the national Lifeline level, but also for those local crisis call centers. I'll say President Biden, in a proposal that he put out just before the State of the Union last week, called for nearly $700 million to build this Lifeline network and associated crisis services, with money for the first time potentially going to those local crisis call centers from the federal government. That's absolutely needed. We can't set this expectation and not provide additional resources. And it's going to take, again, federal, state, local investment to make this all possible, but also providing, resources to expand these mobile crisis teams and make them more feasible in more communities across the country, increasing the mental health block grant to get services, fill the gaps in states and provide states with that funding, and also requiring insurers to cover crisis services, which often doesn't happen and is an important component of this. So I share all of this just to let you know that there's a lot that needs to happen at the federal level, but as you talk to state policymakers, just giving them an understanding of what you expect and what needs to happen at the state level is really important. And I'll just close on this last slide and then hand it over to Laura. But this is a fantastic graphic. It's based off of the Connections program in Tucson, Arizona, and basically shows how many people can be de-escalated in their crisis resolved, their immediate crisis resolved at each point in this continuum of care that I talked about. And this shows you why 988, the number, is absolutely critical, because 80% of calls can be resolved with those trained crisis counselors over the phone. But we need we need these other services for that other 20% that are often the people that NAMI represents, the people that are experiencing really acute crisis episodes. We want to make sure that they have alternatives to law enforcement, emergency rooms. We want to reduce hospitalization, reduce incarceration and homelessness. And there's strong data here to show that people can remain stable in the community if we connect them to the resources they need. And I think that's the basis of this 988 crisis system is really building this continuum of care and helping people be successful in using our limited resources to the best effect. So with that, I will stop. Happy to answer any questions, but very excited to hear Laura's talk a bit more about call centers and the Lifeline.
Great, thanks, Hannah, and thank you to NAMI. You've been a great partner both nationally and I know as part of the state conversations with crisis centers. So really appreciate that. I'm going to try to share my screen, and please bear with me because I am not able to just yet. I think I may need to be made a host as well.
Yeah, Hannah, can you make Laura the host?
I just tried to do that. Did that work, Laura?
Yep. Now let me see if we can share my screen. And I'm working off of one screen, so we may have just a little bit. But let me see if we can do a slideshow.
And somebody put in the chat that that last graphic was a really great graphic, and it was. I can imagine legislators would really, they would really bring that home to them. So good job.
Okay, I am not able to share a slideshow.
It just, there it goes.
So I'm just going to make it really big here and in this side, and you'll see what's coming. So I do want to just start with a disclaimer that the views, opinions, and content expressed here and by Vibrant do not necessarily reflect those of the federal government because the Lifeline is a federally operated program. They may not necessarily share these same opinions, although I'd like to say, if you like it, they'll take credit for it. If you don't, then you can just throw me under the bus. Hannah talked a little bit about this, about 988 being designated as the universal telephone number for the National Suicide Prevention Lifeline, of which Vibrant is the administrator. And so this is really important because when we think of 988, it's not necessarily a new service or a new crisis line that has to be created come July, but it's just making the existing service more easily accessible and helping to promote the awareness of what already occurs now. And I think that's a core component because sometimes people think that we have to reinvent the wheel. And that's not necessarily true because the Lifeline, as you'll see in this next slide, has been around since 2005. And it is accessible through the 1-800 number, so 1-800-273-TALK, available through voice calls, texting, and an online chat portal. And our mission is to effectively serve everyone who could be at risk of suicide in the United States. And what we like to say, everyone, everywhere, every time. So every time that you may be experiencing a moment of distress or your loved one is, you can turn to the Lifeline. Unfortunately, a 1-800 number is difficult to remember if you're not in a crisis, and nearly impossible if you are, or if you're watching your loved one go through a crisis. And so having 988 as that universal telephone number will increase that accessibility. The Lifeline is truly a federal and state partnership with the idea that the federal funding that's provided by the Lifeline, by Congress to SAMHSA for the Lifeline is used to create what we call our nationalized services. And that includes a nationalized voice backup service, our chat and text services, and a Spanish sub network. So I'll walk you through how that works currently and how it will work under 988. So you call the telephone number, in this case, 1-800-273-TALK, soon to be 988. You hear a greeting. If you're a veteran or you're calling about a veteran, you can press 1. If you are a Spanish speaker, you could press 2. And if you don't press 1 or 2, then you are transferred to the crisis center serving your local area based on your telephone number. There are nearly 200 crisis centers in the network. and 8 in Tennessee. And that local center has about 60 seconds or so to answer that call. And if they don't, we pull it back and we put it into, again, that nationalized call backup network. The idea is that every call, chat, and text would be answered, ideally at that local level, so that you can have access to those resources that Hannah referred to. And if you need a higher level of care, you can be connected to a mobile crisis team or another in-person intervention. So that's always the preference, to have that localized response. But if that is not able to happen for whatever reason, the crisis centers work as hard as they can with the resources they have. You still have a chance for your call, chat, or text to be answered in one of the nationalized services. What we have seen historically, though, is that the majority of our crisis centers in the network report that they do not receive state or local funding to answer Lifeline contacts. So again, those calls, most likely that's the majority of the contacts to the Lifeline are via call, but we do have chat and text options. And so if they aren't able to answer locally, then that shifts the burden, right, to the federal and the backup and the nationalized services. What we have been doing with this transition to 988 is helping states understand that this is a partnership, and the work that those local crisis centers do divert from those costlier interventions that Hannah showed us on that last slide. And when we're able to divert from those costlier interventions, we are keeping people in the community and thriving. And that's where the state and local governments were expected to invest in their local crisis centers. And I'll just note here, you'll see here, we have, again, close to 200 centers, 9 current national call backup centers, roughly about 42 chat and text centers, and that's fluid. Again, centers may come in and out of routing for chat and text based on their availability and needs. We have 3 centers that are in our Spanish subnetwork, and then the Veterans Crisis Line backup. So again, you can reach the Veterans Crisis Line by pressing 1 when you call the Lifeline. In 2021, we received about 3.6 million contacts. So again, that's calls, chats, and texts. And that does include individuals who went to the Veterans Crisis Line because they have to call the Lifeline number first. So the Lifeline partners with Columbia University for evaluation of our services. So these are just some kind of top line stats around the Lifeline being an effective intervention. And our role as administrators is to making sure that every crisis center in the network is able to meet the clinical standards. They agree to follow best practices in suicide prevention and care and other protocols. So we know for every 1 person who dies by suicide or completes a suicide, 316 people are seriously considering suicide. The Lifeline, our first year in operation from 2005 to 2006, received 46,000 calls. We received 3.6 million last year, so quite a jump, and over 20 million calls over the course of our existence. 95% of calls are connected within that first 60 seconds. So again, that gives that local center a chance to answer. And then kind of 60 to 90%. So that incorporates people going into the national backup as well. Currently, the counselors are able to de-escalate distress and in 98% of cases, so less than 2%, the call does not involve an in-person intervention. So there's no need to call a mobile crisis team. There's no need to involve police because that individual was able to reach a trained counselor who performed the risk assessments, who provided interventions and helped keep them safe. And that 2% of cases where mobile crisis or another in-person intervention like police may be involved, that is done with the consent of the caller. And so that caller has acknowledged that they need someone to come out. Ideally, that would be a mobile crisis team, but we know mobile crisis teams aren't built out in every part of the country. And so that does utilize or require us to use law enforcement and rely on them. 90% of callers reported making that call stopped them from killing themselves or completing suicide, and that the follow-up services kept them safe. So crisis centers can also perform the follow-up service to make sure that individual got connected to the follow-up care, they attended their appointment, or just checking in on them the next day. And this is a little bit more about our effectiveness, kind of evaluated by other sources, including Columbia University. We talked on how 988 will help build and expand the Lifeline, so increasing the scale of access and availability, helping people remember the number, the scope of service, as Hannah mentioned. So we are marketed as a suicide prevention line, but roughly only about a quarter of the calls are individuals who are in active suicidal distress. So it is a huge focus on that mental health crises, mental health emergency portion. Equity of service, making sure that we are reaching marginalized communities, communities that need additional supports, and frankly face additional discrimination, which can lead to mental health crises. Making sure that they know how that we are providing services however people need them. So not everyone wants to have a phone call. So we have incorporated chat and text options, and always looking for in getting our services in front of people where they are. And again, specialized communities and stakeholder investment in the service. And again, those partnerships like Columbia University that measure the effectiveness of the Lifeline. And then we take their feedback and incorporate that into our trainings that we offer. So Vibrant has undertaken an analysis of what could happen that first year of 988. And we did this by working with other countries that had a 3-digit number, by talking to our public safety, PSAP, NINA, NASNA partners, working with our crisis centers who may also have other crisis lines that they answer. We sort of modeled out 3 different scenarios based on a marketing campaign that would be completed by SAMHSA and others. So in a low volume, that first year, we could see it jump to 6 million contacts, calls, chats, and texts, which would represent a doubling, right, of the current volume. In a medium volume scenario, that would look like 9 million calls, chats, and texts, which again represents a tripling. And then in a high volume scenario, 12 million contacts that first year. And so you can see how it scales. It does include the baseline volume, again, that we expect to be diverted from 911 and other crisis lines, and then new volume, so individuals who were suffering in silence and didn't feel like they had a number they could call. So just quickly, how we're preparing for this transition. We have partnered with 50 states and territories to have planning grants for the states to bring everyone to the table. Tennessee was one of them, and did fantastic work on addressing how to build capacity and ensure that everywhere has Lifeline coverage. And then working with our other partners in both training and marginalized communities, so that we're building this in and building that trust. And part of it, building that trust, is knowing when to call 988 and when to call 911. And so we think of this as the right intervention at the right time. Certainly we respect the work that our 911 partners do, but 988 and the work of the Lifeline is a little different. With 911, as Hannah mentioned, you know that someone's coming out. You're calling because you need someone to come out. And that dispatcher, the person that answers the phone, gives you 3 options. Do you need fire? Do you need EMS? Or do you need police? And they keep you on the line, they get your information. But with 988, the contact is the intervention, right? So again, in the majority of cases, 80 to 98%, right? 80 is the estimate that we saw, and 98% is the current statistic. Just talking to someone is enough. So the trained counselors, the average call time is about 20 minutes. You're not presented with a relay of options. You're not presented with, well, who do you need? You talk and you build rapport with that person, and they again provide the risk assessments and the interventions. And again, they can link you to other services as needed. The crisis centers have referral resource databases, again, linking you to mobile crisis if needed, but it's a different intervention. And so we want to be very clear about when to use which. Just some data that Vibrant has undertaken on 911 dispatch, looking at 911 dispatch per Lifeline calls. So again, right now the calls about 23% that the individual is in active suicidal distress. They need an active rescue or at imminent risk. 2% require 911 dispatch. And then you'll see that it's a little bit higher for the chat portal. And again, looking at it from the 911 side, we've estimated about 8% of the 911 calls. This is based on New York City and NENA data, which is the National Emergency Number Administration. So they kind of work with 911 and PSAPs. About 8% of their calls are purely emotional disturbances, emotional distress that could be better handled by the Lifeline. So I'm going to go through this because I'm going to give some time for Jennifer's presentation. But one of the things that we undertook as part of our planning grants was making sure that we were kind of getting us to this July date and then also thinking about the time after that. So of course, like I said, this isn't a new service. This isn't a switch that will be turned on. There will be time to build out some of those pieces of the continuum, although we don't want to wait on that, but we want to start having those conversations now. But I think as the large front door, it's really important that the crisis centers have the capacity that they need to answer those calls, chats, and texts locally, ideally within that first 30 to 60 seconds, so that we're connecting people to care. And part of the work that you all did in Tennessee was thinking through, how can we achieve 24/7 coverage of the Lifeline so that everywhere in Tennessee is covered by a Lifeline center. Is there sufficient capacity at that center? What are the workforce needs? How are we incorporating peers and individuals with lived experience? What are the existing array of other services, mobile crisis teams, and how can we connect them through to the centers and make a coordinated system? And then, of course, how are we going to pay for all of this? And I think Hannah appropriately touched on a lot of the options available, including state appropriations and a fee. And then just for us to think through that, we need everyone at the table. So I'm going to end there and give Jennifer a chance. So I'm going to stop sharing my screen. And then hopefully I am still in the meeting.
Great, thank you so much. And then if you could make Jennifer the host.
Alyssa, do you mind being the host for this one? Do you mind?
Oh, no,
Okay, that'd be awesome. Laura, I really enjoyed your presentation, so you can keep talking as long as you would like. It's very helpful.
That might buy me some time to figure out how to transfer this back.
Just go to the three dots at the top of your screen to the upper right. If you take your cursor.
Okay. Oh, this is embarrassing.
It's okay. Jennifer, do you want me to do your PowerPoint? I've got it queued up. Okay. Okay.
Yeah, Alyssa, that'd be great. Thank you.
Okay. So, Laura, I need you to enable me as the host so I can share my screen. So another way to do it would be to, so take your cursor and go up to, put it like right up here on your screen. I don't know if you can see it. And there should be three dots.
I'm not getting the three dots.
Can anybody else help me figure out, or maybe I'm not explaining it right?
So I think if you go to the participant list And if you hover over Elisa's name, I think it should give you the option to make her host.
Yes, thank you, Hannah. Saving the day.
I'm the host now. Okay, excellent. So I am going to share my screen and we have Jennifer's presentation. Jennifer, if you just want to tell me when to go to the next slide.
Sure, thank you. So I talk with my hands, so it's very hard for me to also remember to click on next slide. So thank you, Alyssa. And I have to say, I was sitting here listening to Hannah and Laura, and I feel like, I'm sure you guys would agree, I feel like we talk about this probably 17 times a day, which is a great thing. But I feel like no matter how long after we talk about it again, we've already made huge strides. So, just in hearing kind of like what are the historicals behind 988? What are the fears about 988? And where are we now? I feel like Tennessee, and I think that you will see, are leaps and bounds ahead of where we were even 6 months ago. As part of, I think it was Hannah, one of Hannah's slides, it mentioned something along the lines of if we don't do something, we're going to be inundated and not have capacity. I'm excited to say, I feel like Tennessee is poised in a really, really good place. And you'll see that through some of the preemptive investments that we've already made over the past 2 years, we've improved our in-state handle rate, and we're getting some really good data around a pilot we recently started to really poise us for July of this year. And then the second thing before we get started is there was the infographic that you all mentioned that Hannah showed. We actually in Tennessee have one just like that. So if you go to our website, go to the crisis services, you will see there's a video that basically shows you what one can expect when they call a Tennessee-based crisis line. And it's exactly what Laura lays out. I mean, the goal is to allow people to define their own crisis, whether it be consultation about my mom, whether I'm in acute crisis, whether I really just need assistance finding referrals in the community to diffuse what may become a crisis. So that's really a priority of ours. And then the other infographic, it speaks to what Hannah showed, was truly the diversionary efforts that go on at what we call our front door, and how many of those are diverted from ever even needing a face-to-face intervention. So if you guys have a chance to take a look at that, they're both on our website. I believe we just updated with the most with the recent fiscal year's data. So take a look there. I will say, this work is kind of what I started out in Tennessee in crisis services. Is I've started 15 years ago now. I feel like COVID made me jump 2 years ahead. But 15 years ago, I started at crisis services at at the time they called the triage coordinator. What that really meant was we have a local call center, one crisis line, plus the Lifeline. We need to grow this out nationally. And so that was my job, was to basically build out a national call center. And so I worked with Laura's team very closely over the last couple decades, implementing things like the national NFL crisis line. So we have people in Tennessee that have that experience and investment, and you'll see our 6 call centers have been in this work for a very long time. We also have somebody, one of our providers actually in this network that sits on their advisory council. So there's a lot of investment around the success of this initiative. But what I want to speak to today really is kind of what does our infrastructure look like now, just in general, in terms of crisis services? What do our front doors, how do people access services? And then really speak to what we've done as a department to preemptively prepare through funding in prep for 988 in July. So this is something also you can find on our website. This is what we call our Downstream Snapshot. So if anyone is deemed, when they call one of our crisis line, if anyone is deemed needing a higher level of intervention, meaning mobile crisis, to determine if there is a higher level of care needed, this outlines where those services are and who provides those services. So Tennessee has had mobile crisis services in place since the early 90s, so for a very long time. And we contract with 13 providers across the state, and they're color-coded here so you can see kind of what provider covers what area. But their role is really to go out, meet them face-to-face, telehealth, whatever medium necessary, to identify what level of care is needed to diffuse that crisis and connect them with resources. And then beyond that, we do have other higher level of care type resources in our back pocket through things like our walk-in centers. We have 8 walk-in centers across the state. So somebody can just walk in and receive a crisis assessment in-house, similar to what mobile crisis is, but it's obviously in bricks and mortar. And then all of our walk-in centers are tied to a crisis stabilization unit, which is a higher level where they would get, med management, therapy services, really get that stabilization they need to be able to be discharged back home and avoid inpatient stay. We also have respite services across the state. Our substance abuse side division of our department does contract with 7 providers to do medically monitored withdrawal management or detox throughout the state. And then we also have 4 state-funded, as many of you know and are familiar with, our regional mental health institutes. And so this map just shows you kind of where they are. I will say that through the most recent kind of budget proposal process, we are hopeful that we'll be able to work with Governor Lee to use some of the the Rescue Plan Act money to add some walk-in center and CSUs across our state, because we do know that there are some gaps in some of our more rural areas. And we know that those diversionary services also help get folks where they need to be real time. Next slide, please. All right, these are Tennessee's front doors, we call them. Each of through our contracts with our crisis providers, they are required to have a 24/7 crisis line where they do that real good triage, work care coordination, and follow-up services. So in fiscal year 21, the agency level crisis provider lines took 112,070. We also have a statewide crisis line that, based on the county of origin, it rolls to that actual crisis provider in that county to the exact same work. Then we also have the Lifeline network we have 6 providers in. 3 of them are also crisis contracted providers to provide other services. 3 are independent. And then last fiscal year, they took a little over almost 31,000 calls. So you can see there's a lot of good work going on at the front door. Right now, we collect data on all of our crisis services in a centralized, what we call crisis management system, that can really splice and dice data around who's coming to the front door, why are they coming, where are they coming from, what was the disposition, to really help us look at gaps in services and QA. Next slide, please. And I think Laura gave a little bit of an overview of this at a national level, but wanted to kind of also speak to this more at a local level. I know out of the gate, there was a lot of fear that, oh goodness, we're going to lose so many calls out of state. But I wanted to outline kind of how we're set up in our state. Happy to say that we are and have been for a very long time. We have coverage in every county in Tennessee. We have a primary call center. We have a backup call center in state to keep those in-house. So what happens is, and it's one of those 6, what happens is someone dials that number, the county of which they're calling from, it routes to that provider that's covering that county as primary. If they don't answer, the national standard is 30 seconds. If they don't answer within a certain time frame, it rolls to the in-state backup center. If they don't answer with a certain amount of time, it rolls then to that national backup center. So while we absolutely want to have at 90% at a minimum answer rate in state, I just wanted to point out that those calls are being answered by somebody, so those folks are getting the assistance that they need. And our partners for Nspl, soon to be 988, we have Family and Children Services out of Nashville, Tennessee. We have Frontier Behavioral Health out of East Tennessee, Centerstone out of Middle Tennessee, Memphis Crisis Center, obviously out of Memphis, West Tennessee, Oak Ridge, also out of East Tennessee, and then Volunteer Behavioral Health out of Middle East Tennessee. So we do have presence in each region, and we'll continue to hopefully expand that moving forward. Next slide. All right, so the next, I think 2 slides is really speaks to kind of what we've done as a department to support them. I know Laura would totally agree, and those of you that have done this work would totally agree. Our call centers do this work for the right reasons. They do this pretty much for free. I mean, and Vibrant only has so much funding that they can provide, and so I know they're very grateful to get anything. But the fact that they've been able to not only provide this level of service with the volume that they've had and sustain that is beyond me. And so about 2 years ago, maybe a little over 2 years ago, Vibrant came out with what they call the Nspl capacity building grant. And I don't know if you've looked at the different funding opportunities, but I feel like it's been pretty serendipitous in the way things have actually worked itself out. And each one is kind of built on the next for us. So we applied for that. It was $203,894. And really that was, I think, well, I know the state's first formal effort in supporting these centers, really to figure out how to start thinking through what is our routing plan, what is our true capacity, how can we support those that are struggling, what makes most sense. And so what Tennessee decided to do was to fund the 3 centers that were struggling the most in terms of answer rates. We added infrastructure. We knew we'd have to figure out a way to sustain that. So the timing was perfect for the block grant coming out. But we were able to increase our answer rate by 8%, which is big. It's not obviously where we want to be, but prior to those efforts, we're at 59% in-state answer rate. Post that, as of September 30th, we were 67. But we learned a lot. We learned a lot about capacity. We started to look at data around what can based on average handle time, who's coming to the front door and the needs, how many calls in a certain amount of period can one full-time equivalent handle. So we did learn some things there. Then, as Laura mentioned earlier, Vibrant put out what they call the 988 planning grants, which we obviously applied for. This concluded at the end of January, but we are not done. Obviously, we were funded to formally do this work. And I think really what that funding provided for us was making it official that we had to create a stakeholder group to really drive this work. I know Jeff Layden with NAMI's on our planning coalition has been very active in those meetings and calls. We partnered with the Tennessee Association of Mental Health Organizations to implement this. And it really was to think through, what is our strategy going to be? How are we going to determine what we need? And is the sky really falling? And so we met monthly with our planning coalition. We created what I feel to be a really robust implementation plan, which I think you'll kind of see hints of that from the next pilot that I'm going to talk about. But we decided that as a state, we wanted to use true in-state data that we know to be completely accurate to determine what our needs may be. We worked with 911 kind of out of the gate to say, is there a way we can gauge what the average percentage of mental health call or average 911 calls are mental health calls? Unfortunately, there was no standardized data capture around that. So what we decided as a state was we're going to right size as best we can using funding we have available to right size this shift, hopefully over prepare to capture what we think may be a slight increase out of the gate and really be strategic around our marketing efforts. So the planning grant was really, really integral in making those types of decisions, but we really are using a data-driven approach. I think what came out of this, the biggest thing for me was, because there was so much focus, was we got approval after a great proposal. We got approval to use the mental health block grant crisis set aside, which is annual recurring funding, even better, to really truly beef up capacity and really truly start some real good data collection around call dispositions and capacity. We can go to the next slide.
Oh, and Jennifer, this is Lisa.
Yeah.
We're getting a little short on time, and we still have one more speaker.
Oh,
so,
okay.
Yeah.
I can jump through this. So this is the big, we could have just gone to this slide because this is my favorite. So more than anything, we used the set aside. It was almost $700,000 to really beef up our call center capacity and not only identify and enhance our routing plan, which we did, to start collecting data around things like downstream impact. On average, what percentage of those calls resulted in mobile crisis referral? We know our data around the other services and kind of the downstream impact there. So we are able to look at, based on potential call volume increase, what capacity needs they're going to need to be in the other parts of the crisis continuum. I will say we are actually, as of last month, at 86%, so a 26% call handle rate increase since we started this work, which is wonderful. We went live with this August the 1st, and again, this is recurring funding. Next slide. And this will be my last slide. I won't have to go because I think I spoke to pretty much everything on the last two. We did apply for the SAMHSA funding. We hopefully will be awarded 1.688, not only to stand up call center capacity, but also to start to build out chat and text capacity within our current system. We already have one of our 6 is a chat text center, has been a national chat text center for years. So they've agreed for us to fund them to be our pilot site, with 2 other centers we're funding to actually start to dabble in that work. So overall, I think we're in a really, really good place in terms of strategy. And I think we're going to be poised to do really great work specific to this. And I think I'll stop there since you had a whopping 6 minutes left. Sorry about that, Alyssa.
Oh, no, that's fine. That's fine. There's just been a lot of really great information here. So where we're going to go with this conversation next is our last speaker, and then we'll take some questions. And there was a really great slide that Laura had about how does 988 expand and build upon Lifeline. And Hannah spoke to these opportunities that 988 brings. And I decided to invite Dorshonda Evans, and she is the Member Engagement Director from the Rural Health Association of Tennessee. Because when we talk about these calls and referrals to services in the community, mobile crisis stabilization units, what do we have in our communities, and how will our rural communities be impacted, and our communities of color? So Dorshonda Evans comes to us, like I said, from the Rural Health Association of Tennessee. She's a nurse, a professor at Jackson State Community College, and she is a committed health equity advocate. So let's go ahead. Dorshonda, are you unmuted?
Yes.
See. Great. There you are. And so tell me about your organization.
So the Rural Health Association of Tennessee is a member-led organization that has been around since 1995. And through member involvement and through like questionnaires and needs assessment surveys, we identify and work to resolve healthcare issues through service, education, and advocacy.
Great. So can you tell us what mental health access looks like in rural communities?
Yes, so in speaking with some of our members, I was able to find out that patient access looks like approximately 3 to 4 weeks just to get a mental health assessment, and then another 3 to 4 weeks to get an appointment with a psychiatrist to stop or change medications. And then that doesn't include any additional referrals that are needed as well. So we know in looking at this that there are no 2 rural communities that are the same. Some have FQHCs, some have RHCs, some have hospitals, but then the services for those communities do also differ as well. So in looking at that, we need to just advocate and really realize that there is an extensive amount of time that it takes for someone to get those services in rural communities across the state. Another barrier that we have heard about was insurance. So we know that there's approximately 300,000 uninsured individuals here in the state of Tennessee. So if we look into, we know that the Department of Health and Medicaid and TennCare has been advocating and working to extend and expand certain services. But if we can get those 300,000 approximately individuals insured, that means that that's more people insured that could get mental health services in these rural communities and in these areas, along with primary health care. So if you could see your PCP, usually they're the first to realize those mental health status changes, and they can get those referrals out if we could just expand our Medicaid insurance coverage.
Mm-hmm. And that's certainly something that we've been advocating for at NAMI Tennessee for a few years now. And then when it comes to mental health access, what does this look like for communities of color?
So with communities of color, we know that there are, number one, language barriers. In some communities, it comes down to something as simple as having something in print or having an interpreter or someone that could break through those language barriers and provide those resources. And I did and I saw on several slides that the 988 does have several languages. So it's going to break across barriers that anyone could use and be able to communicate those numbers to help get the services that are needed. Also, the stigma around getting help, mental help for communities of color. We know that usually it's kept quiet, it's pushed under the rug. As a person of color myself, I've experienced that within my family and my community as well. Also, you go to your faith-based leader if you're a parishioner of a church, and you seek counsel from them because they're usually pillars in the community. So providing those resources, and a resource like the 988 hotline. Yes, please get go to the service, get fulfillment, but also at the same time, use those resources so that when you leave that congregation and you leave those people that you're close with and you're alone, you can use the resources at your home or in your community to seek help if you need it.
Mm-hmm. And I know there was mentioned earlier that there's going to be a lot of marketing around this 988 line next year in 2023. So, we'd certainly like to see, different messaging for different communities, possibly, or tailored for that. And then how does workforce play into this, a shortage of mental health professionals?
So we know that 91 out of 95 counties in the state of Tennessee are healthcare professional shortage areas. And I think also reaching back to communities of color, there's a lack of diversity in healthcare. And if we could educate providers that are not of color in cultural competency and cultural norms, and also provide diverse care, I think that will help in communities of color. Also, in rural counties, we are beginning to think outside of the box. So I do love that Jennifer actually had two of our members, Buffalo Valley and the McNabb Center, were highlighted and actually got awards. They were nominated for thinking outside of the box and using those mobile health units, or as they call it, the mobile buses, to go out into 5 different counties each in their areas, and doing those mental health assessments and having those mental health needs. We know that there are hospitals and clinical shortages because some have been shut down across the state. And you don't have those services in a lot of rural communities. So what they've done is they've taken the clinic to the community in a sense, and they've broken down a lot of those transportation barriers in rural. So there's a lot of compounding things that feed into not being able to get access to care in rural communities, but they've broken down those barriers. And in doing so, not only can they provide mental health resources and wellness resources, but also they've expanded to primary care resources and being able to provide primary care on those mobile units as well.
Mm-hmm. Okay, great. So you can see from this discussion how the 988 will feed into community resources, and then what do those community resources look like and where are the gaps? So we have a lot of opportunities here with this 988 launch. Does anybody have any questions? We're already a little after our 5 o'clock hour here. We can entertain a couple questions. I just want to thank all four of you all for bringing your expertise here with this. We do get a lot of questions about 988. It's probably the single most issue I get emailed on at NAMI Tennessee. So we're glad to have the experts here. Dorshonda, was there anything else that you wanted to mention just in closing?
In closing, what we're doing to try to bridge the gap when it comes to lack of diversity in care, if you know of any healthcare professionals, mental health providers that have been practicing for 2 years or less that are interested in taking, or community health workers that are interested in taking a course on anti-stigma based around cultural competency, or a diversity training course, we will provide a stipend to take care of that if you're interested. So Tennessee Rural Health, tnruralhealth.org is where you can email to get more information.
Great.
And info at tnruralhealth.org. Sorry.
Great. Thank you. We did have a question. Are there any psych survivors on the 988 planning committee? Jennifer, that might be your question. I know they pulled together a lot of people from the organizations like NAMI Tennessee and the mental
Oh, you
health
mean that?
organizations.
Sure. Like who else on the planning coalition?
Yeah.
Yeah, just a wide variety of stakeholders. We have NAMI, we have AFSP, we have TAMHO, we have EMS, Chief of Police Association, Sheriff's Association, THA. We have all of our crisis call center providers, just a wide variety across the state.
Great. Let's see, I didn't see any other questions. So thank you so much for being here. You all have provided just a wealth of information, and thank you for your time. And yeah, I think that's it. Thank you for telling us all about 988 and opportunities that we have moving forward. Bye, everybody.
I thank you for having us.
Mhm.
Thank you for the work you all are doing.
You're welcome.
Thank you.